So hello, I'm John from 33N and the National Clear Programme Communications team, and I'll be hosting today's Mental Health 2022-23 programme webinar. This is the second in our Clear Impact webinar series 2024, where we'll be joined in conversation by leading lights in the NHS and colleagues from the National Clear Programme team to discuss and share the learning and impact from our recent Clear transformation projects. A reminder that today's webinar is being recorded, so we can share it afterwards on our website and across our network. So please do share the webinar recording with your own networks too. So today's webinar centres on the Clear Mental Health 2022-2023 project, and it's entitled Transforming Mental Health Services, Enhancing Pathways and Improving Access. We'll hear how Clear supported Cheshire and Wirral Partnership, Cornwall Partnership and Norfolk and Suffolk NHS Foundation Trusts to design new models of care and optimise their workforce to transform key mental health services. Okay, let's have a look at who we're joined by today, please, Alex. Okay, a big warm welcome to our speakers, Mike from Cheshire and Wirral Partnership NHS Foundation Trust, Gail and Magda from Norfolk and Suffolk NHS Foundation Trust, Christiana Silva, who works for 33N but worked on the Cornwall Partnership project back in 2022-23, and our very own Claire Perkis, who's the project sponsor of the National Clear Programme. Okay, a quick run through today's agenda. Claire will provide you with an overview of the National Clear Programme itself, and then a more detailed overview of the Mental Health Programme 2022-2023 before handing over to Gail, Magda, Mike and Christiana, who'll talk us through their key findings, recommendations, quick wins and projected impacts. Claire will then host the personal reflections segment, and then we'll open the floor up to Q&As from yourselves, whether it's a hand up, raising your hand emoji, or whether you want to put your question in the chat to us, and we'll respond accordingly. So that's it from me. I'll hand over to you now, Claire. Thank you.
Perfect. Thanks very much, John. And yeah, thanks to all for joining us today. So first off, just an overview for anyone that hasn't seen any of our work or been to one of our webinars before. So the National Clear Programme was originally developed in partnership with Health Education England and it's sponsored by NHS England, regions and systems. And the real aim of the programme, as the next few slides will kind of go on to describe, is to really put clinicians at the heart of service redesign and transformation. So really giving a voice and sort of some power to those that are kind of really seeing it at the front line and really involved day to day in patient care. Let's skip on to the next slide, please. So how do we do that? So we have our clear approach, which follows through 4 different key phases, and each of our projects will go through each of these phases. So we start off with clinical engagement. And this is a really exciting part of the project where it's kicking off, where the associates and clinicians that are on board with us will go out and speak to a really diverse range of stakeholders across the healthcare setting that the project is happening in. And the purpose of that is to really understand the demand and the lived experience of the frontline team, understand what the challenges are in that particular area, but also what's working well. And that all then gets collated into the key themes that come out. So again, grouping things together, a kind of adapted thematic analysis to really pull through those recurrent themes. The second phase is data interrogation. So that's when we then move on and look at the locally collected quantitative data. So again, our team will extract that data, it gets put into dashboards, and then the associates that are working on the project will then analyse that to look at, again, key performance indicators, service use, and again, see if that marries up with what's been heard in the clinical engagement phase. So that information is then all triangulated. So we take the views of the frontline staff with the quantitative data and pull that into, again, some kind of key challenges that are really emerging. Those challenges are taken forward into the third phase, which is innovation. So innovation is a chance to kind of really go wild, try not to be bound by previous views, think differently about how things could be working in an ideal world. And again, what changes could be made and what a new model of care could look like that addresses those challenges that we've heard in those first two phases. We'll also do detailed workforce modelling in that. And again, that can be done across different scenarios. So you can have numerous different options for that new model of care and workforce. And again, what you come out with at the end is a costed model of care. And again, linked to impact. So if this model of care was put into place, what would be the impacts that you might see? And that would look at things like financial impact, impact on service users. So again, perhaps it's getting access to appointments quicker, less wait time, better outcomes at the end, better experience of care, and also impact on staff. So again, hopefully if things are working better, and things are working more smoothly, that's all around much nicer for staff, and that may be realised in things like better recruitment and retention. All of this then gets pulled together in phase 4, the recommendations phase, into a lovely report that details again that journey of how those recommendations have been arrived at, and again the potential outcomes if those were then implemented. So again, that's kind of the end output at the end of each of our clear programmes. If we move on to the next slide, please. So this is a kind of slide just showing kind of lots of the different projected kind of outcomes of sites that have taken part in our clear programmes. So obviously end output is that you end up with the recommendations, like I said. So you get care and workforce redesign, you get the opportunity to look at the data. We've got really good IG in place. Again, obviously we really make sure that we're very robust about the way we deal with data, both qualitative and quantitative. But also there's the wider benefits. So again, what we hope is that through people participating in this programme, it's a real opportunity for people to have the headspace to gain new skills, new knowledge that not only gets used in this project, but gets taken forward into future projects as well, and that learning can then be disseminated and used more widely outside of the project itself. And obviously, as with anything, patients are at the heart of everything. So again, if we can support this work, then again, hopefully the overall outcome is improving that patient experience and care. If we move on to the next slide, please. So you can see we've done projects across England in lots of key priority areas. And again, I won't run through them all, but as you can see from the map, we've done urgent emergency care, right through to kind of ophthalmology, lots of primary care projects. So we've done 50+ projects already, and we've got more currently underway as well. So lots of exciting work coming out of those. And again, I've kind of already touched on this on the previous slide, so I won't dwell on it too much, but really what our overall aims of the programme is to really empower that clinically led culture. So putting people that are experiencing it, living and breathing it every day in control of making change, empowering staff with new skills that they can take forward to, again, future transformation projects or future job roles. Hopefully getting some good outputs that come out with new ways of working that are more efficient and better all round for patients and staff. And I think we've already said that clinical ownership. So again, very much working with trusts, with colleagues, with staff to co-develop these recommendations and really giving that ownership to people working on site. We move on to the next slide, please, Alex. Again, I won't go into detail in this, but this is our kind of high-level overview of each of the 26 weeks of our Clear Complete programme. So you can see it's broken down nicely into the clinical engagement, data interrogation, innovation and recommendations phase. And I'm sure the colleagues on the call that have joined us that have been through this will look back with varying degrees of fondness or not at certain of these phases, depending on what your preference was. But it's a jam-packed programme. There's a lot to take in. It's very fast-paced. But again, we really do hope that the skills that are learned in this are skills that are useful and taken forward into people's day-to-day job roles as well. If we move on to the next slide, please. So our Clear Mental Health programme, I was just reflecting, I can't believe that it finished a year ago. So it ran from October 2022 and finished at the end of March 2023. And so it just goes to show how time flies. But this was our second National Mental Health Transformation Programme. So we'd run a previous wave of mental health projects in 2020, 2021, which resulted in 30 recommendations to reduce waiting times, improve access, extend capacity and increase staff retention. And again, so this was really kind of building on the success of that previous programme and looking again to support trusts to kind of achieve the aims of the NHS long-term plan. So if we move on to the next slide, we can see where this project was. So I think when we kicked off, I mean, you can see on the map, we couldn't have been more spread out in terms of sites. There was no easy central place. So a lot of our face-to-face work ended up in London. But we had 3 amazing trusts that took part in the programme. So we had Cheshire and Wirral Partnership NHS Foundation Trust. So up there on the, I'm trying to think how it looks to everyone top left, I'm hoping. We had 2 projects running in Cornwall. Again, couldn't be much further from Cheshire and Wirral. And we had another project running in Norfolk and Suffolk NHS Foundation Trust. And so collectively, those trusts have about 13,000 staff and serve more than 3 million people across England. So, you know, huge potential scope for impact for each of these projects. Each of the projects had a different focus area for mental health. And again, you're going to hear more about these with our speakers shortly. So I won't dwell too much on each of them, but NSFT focused on their dementia intensive support team in East Suffolk. And this was a service that was facing a really increased demand and had some mismatch in referrals from patients in crisis. So and some challenges around unclear referral criteria. So again, they were really keen to see how that service may be improved. Cheshire and Wirral were looking at young people's transition services, so how to improve children transitioning from child to adult mental health services and reduce variation that was happening in those pathways across the trust, which were leading to sort of different experiences and potential inequity of patient care. And then in Cornwall, we had 2 projects. So we had one that Christiana's going to talk about that was looking at realigning community mental health teams with primary care networks. So again, it was felt that the boundaries were not matched as well as they could be, which was again leading to discrepancies in caseload lists, thresholds and wait times. And then a second project that was looking at the kind of gap population. So those patients that were referred into mental health services by primary care networks, but were deemed not to meet the threshold. So we then bounced back to primary care and kind of sort of bounced around in the middle a little bit, you know, without sort of a clear programme of support in place. So looking at, again, who those patients were and how they could be better supported. So yeah, lots of exciting areas. So I'm going to now hand over to the first of our external speakers. And so we've got Mike coming to talk about the work that was done in Cheshire and Wirral on the transition pathways. So Mike, over to you.
Hi everyone, thanks for joining us today. Yeah, I can't believe it's a year, give or take, since we were finishing. So we don't have long, so I've got about 7 minutes, so I'm just going to crack on. All right, right. This is obviously boiling it down to some very clear, concise statements, but there's a hell of a lot of data that goes underneath all of this. As Claire said, that it's a very detailed project. But what did we find? Well, bear in mind, I'm talking about Cheshire and Wirral Partnership Trust here, which is quite large geographically, and we're talking about Wirral, Cheshire West, where Chester is, all the way over to somewhere called Macclesfield and down to Crewe. It's a big area, so it's a huge thing to tackle. You know, we were looking at transition across the whole trust from all the different teams, CAMS, crisis services, ADHD, ASC, inpatient, outpatient, you name it, in adult services, the CLDTs, the CMHTs. But what we found was there was very few dedicated transition workers in post across the trust. In fact, I was one of only a handful across, you know, these thousands of workers. So yeah, without a doubt, you know, we're talking about these so many different teams, across such a geography, there was difficulty in communication between these children's and adult services. I mean, there was difficulty in communication within the child services, within the adult services, you name it. There was communication was a big issue. It's one of our 4 themes. Variation in processes, absolutely. What Wirral did in one area, we might have done something really good over there, but then there was no such good practice. Sorry, I've not finished, but okay. Yeah, variation across the trust without a shadow of doubt. It's to be expected, but that's what we found, and therefore you haven't got that consistency of quality, and a lack of clarity about what to do and when to do it and who should do it. Yeah, there was a lot of young people. I mean, this is common sense that young people do experience increased mental health difficulties as they progress through adolescence. That's well known. But yeah, there was a high prevalence of accessing crisis services coming towards the age of 18. The data showed that clearly. Obviously, that's problematic because people are changing services at that time, which increases risk in and of itself. Yeah, there was limited education for staff and families. I mean, there isn't an overarching trust strategy, which is the point below. There's no shared pathway. So how do you train to something that doesn't exist apart from general good practice principles? But overall, there wasn't something we could train to, and we couldn't consistently tell young people, carers, and so on what would happen because, to be fair, we didn't actually know in every circumstance. And I've said we don't have a pathway, and but of course, people come into health and this field because they want to help people maintain their health and get better when they're poorly, etc. And staff do want this to work better. That's the bottom line. There's high enthusiasm, but it's not easy, and it's a big trust, as I said. Next slide, please. Of course. So what did we recommend? We obviously thought that not having an overarching strategy was an area for development. So quite rightly, we recommended a trust-wide patient pathway, if you will, a strategy pathway, same sort of thing. Ultimately, what we're trying to set out what we're going to do and how we're going to do it, and how we know that we're doing it. We suggested to set up a dedicated transition team, not to do the transitions as such, but to oversee the flow of young people coming through, make sure we were compliant with the pathway, which is no mean feat, etc. At all. So yeah, we recommended this team be set up. Essentially, we said someone to run the 3 main localities and then someone to oversee that whole process and work across the whole trust. And in doing that, there was obviously practical suggestions. We were saying, well, how do we tackle this communication issue? We get the pathway, we have someone to coordinate it, but we also need forums as well. So we identified good practice, for example, in the Wirral area, where they have quite a robust multi-agency meeting, and we were saying what works well in this trust, let's emulate it in other areas. Of course, it's logical, it's sensible, but it wasn't being done. And then, as it said at the bottom, to monitor the flow of information and the flow of quality and outcomes, and keep an eye on that. And the quick wins were gathering feedback about the transition process. We already have participation and engagement workers in place, and it was appropriate to say to them, can we target the transition age group, people coming in their 16th, 17th year, 18th year, 19th year? How did it go? What did we do well? What could we do better? So that element of co-design, co-production and feedback, we had the raw materials in place to work with that. So we've tried to escalate that internally. Also, if we could get our pathway coherent and deliverable, we could set up information to say what will happen for young people, what's out there as well. So that was the transition information pack. And also health passports. The data shows that we're not I think that's an area that a quick win, because the data showing that there's not a huge prevalence of young people with them. So we thought we could target that using our electronic patient records to ensure that people had them completed in a timely way, which would help through transition, which would help tackle the communication issues and so on. And also, how do we bring people together and to foster a shared purpose and focus and responsibility, bring people together to have away days across the trust. Okay, and the impact was for young people, we're obviously saying if we can get all of these ducks in a row, we're going to improve outcomes. Bottom line, we're going to reduce the need for crisis services. We're going to help people know what's out there, and we're going to know what we need to do per team, per area. The data was showing that there's a high prevalence of crisis service access. As I said, we projected that through the improvements that a conservative improvement would be this 10% reduction. All of this was costed, but it would be too difficult to hit you with hard figures now across such a a range of data. So I won't do that. But yeah, there was without doubt, if we could improve outcomes, reducing patient admissions, which are extremely costly, of course, to the well-being of the individual, but also financially, we could reduce that by better planning. That's absolutely, of course, a win-win. And we need to get regular feedback from patients, young people, parents and carers as well, and also teams. How do we work better together? I'm nearly at 7 minutes. Bottom line here, let's do it better. Let's be more streamlined, and clearly we'll be more efficient, which will lead to better outcomes for the young people we support. There you go. Thank you. I think I'm done.
Yes, indeed. We'll pass straight on to Cornwall Partnership. It's Christiana, over to you.
Hello, everybody. Thanks for coming. I'm going to be talking about one of the projects that we've done in Cornwall. I'm going to be talking about the alignment of boundaries. Essentially, this project was about to realign the boundaries between the PCNs existing in Cornwall with the CMHT. So they have 6 CMHTs and about 20 PCNs across the whole region. As you may imagine, it's a big region, it's all widespread. But what we had was variable workload and not a very good provision of care in overall with the alignment they had. So following the clear methodology, the team understood that there were a few things worth noticing. CMHT processes were poorly understood externally. This means that PCN staff were poorly trained to understand how CMHT worked and how and when to refer, the appropriateness of referrals, meaning that expectations were not aligned with the services a CMHT could provide. The staff resources were being used inefficiently in some teams where the roles didn't match the work that need doing. The CMHT processes varied across the region. There were no standards of care or operations or standards of operations, leading to difference in the availability of services and provision of care, also leading to inequalities. The PCNs and the CMHT seemed to be completely disconnected, and if anything, in disagreement with each other, which made relations and communications a sensitive matter and fragile. And finally, the quantitative data that we had access to was poor, with poor coding, limiting our analysis and the trust analysis of their own services. So to tackle these issues, we have suggested 3 recommendations and 3 quick wins. The 3 recommendations we've done was to realign the 8 GP practices to different CMHTs in order to balance the caseload and patient risk. We've recommended to create a virtual CMHT to assess and treat low-risk patients. This would be facilitated to access the services, especially in the most remote areas of the region, but also would help with recruitment of personnel at a national range, and to hire a data analyst to support and help with the treatment of data. We also suggested that moving on to the next slide, please. We also suggested 3 quick wins. One was the standardization of care provision among the CMHTs. We also suggested that PCNs and CMHTs should create frequent hubs where clinical cases would be discussed and support provided to PCNs, avoiding CMHT referrals and admissions. And finally, we've suggested that a digital source of information where PCNs could find guidance on patient management, referrals, and VCSC sector contacts was created to support PCNs. Next slide, please. So the project impact, in summary, the alignment of boundaries would promote integration and collaboration between primary and secondary care, improving patient care and experience, staff well-being by easing the workload and aiding recruitment, saving NHS. We calculated this amount of money if everything was implemented, about £2 million in the first year. And that's me, I think. and I was very, very quick. So I'm really sorry that I speak really, really quick. And
that was wonderful, Christiana. Thank you very much. It's my fault. The brief I gave all our speakers was time specific, so I'll hold my hand up. My fault. Excellent, as always. Okay, we'll just go on to Gail and Magda at Norfolk and Suffolk now, please. Oh, before we do, any questions that you do have, I know we've got a couple coming in through the chat. If you can save them to the very end, if they're not covered, then we'll address them then. Thanks, over to you, Gail and Magda.
Hello, everyone. Can we have the first slide, please? So when we started to do our project looking at our dementia intensive support team in East Suffolk, some of the issues that came from the key findings were that the referral criteria were really quite confusing for not only the referrers, but also for the staff working within the team. And there was a belief amongst referrers that the team didn't accept anybody's referrals, really. Also, it became very quickly apparent that some of the internal pathways weren't working very well, that there was poor communication between teams and services, and that one of the biggest findings that the DIS team themselves told us about, interestingly, was that they had been displaced from their previous physical base, partly as a result of COVID, and were feeling very disempowered because they had nowhere to have a sense of team belonging. Next slide, please. So as part of the work, we had very big ambitions with our project. We had very big recommendations, some of which have come to fruition, some of which will take considerably more time. One of the things that our work showed us was that the DIS team was doing very good work, actually, with people that they were supposed to be working with, people with dementia, but there is a service gap for older people with non-dementia related mental health problems that is picked up by the age inclusive crisis resolution and home treatment team, and the data was showing us that actually that doesn't always work very well for that service user group. So the recommendations really are around having a diagnostically inclusive hospital at home type approach, crisis resolution home treatment team for older people. And there were obviously recommendations around staffing for that. So the DIS team would be the core of that service, that we would need to recruit and finance additional staff and skill mix within a service like that. And obviously a project like that isn't an isolated piece of work just for NSFT. That would have to be done in collaboration with our stakeholders and indeed with some service user and carer collaboration too. Next slide, please. We identified a number of quick wins, as you would imagine from a project like this, the most obvious of which was to rewrite or clarify the referral criteria so that everybody actually knows what the team is for, have a standard way of operating, and that has actually taken place at the moment. We've enhanced the data capture around who we're, not just what people are being referred into the team, but what happens to that referral when it comes to the team. We found that what was happening was that people would be referred in. The team would say, actually, this isn't a referral for us. We can't take this on for a piece of casework. But what we'll do is we'll talk to you. We'll talk to the person you've referred. We'll do a piece of work that signposts and makes a referral to the appropriate service. So doing actually quite a lot of work that wasn't reflected in our own data capture. So we've amended that as well. The duty worker with the DIS team every day, the plan was that they would attend the meeting with the rapid response team, the physical health rapid response team, so they could identify better opportunities for collaborative and joint working. And a new step-up pathway has been introduced with our community mental health team, so that the DIS team now works with people from secondary mental health services who meet their criteria in terms of the dementia, but are showing marked deterioration that requires a step-up level of support for a relatively short period of time to prevent a hospital admission. Our projected impacts, as you can imagine for a model of that kind, were quite significant in terms of savings, as you can see, up to 2.4 million if admissions are reduced by a year. These are somewhat pinch of salt because it's hard to know, because we haven't yet started that aspect of the project where we would actually be, but these are our forecasts. The team could also support earlier discharge from the acute hospital. So as you can see, 30% reduction in length of stay, brings immense cost savings, and also it brings immense benefits to service users and carers, because all the evidence is that going into hospital for an older person with dementia is really, really harmful in terms of their mental well-being, the progress of their dementia. We're looking at the impacts of what training and upskilling our workforce will be. We're already seeing improved staff morale, job satisfaction and recruitment, and the streamlined crisis pathway for older adults will result in reduced repetition of assessments and duplication of work between services, because it will be a single point of contact. I think we've got another slide. Yeah. So they still have this ambition to have the team changed. We are now fully recruited to the DIS team. They do have a dedicated workspace. We found them some office space. They now have regular face-to-face team meetings. Staff wellbeing has improved. Staff retention has improved. The management structure has been relocated as well. Previously, the DIS team were part of the acute, so the inpatient mental health management structure. They now sit within the community mental health structures, which has given them a sense of connectedness with the community services that they're now working with to prevent admissions. The team's much more proactive in approaching other services to develop collaborative ways of working. They're attending weekly discharge planning meetings with our acute hospital colleagues, looking at how they can become involved as people are being readied for discharge to facilitate that sooner, so to reduce that length of admission. There's an improved relationship and understanding with our GPs and social services, so consistent and improved service user care. The reputation of the DIS team has much improved, which has also had a very positive impact on their own morale. Services are now understanding that actually they are a very helpful and responsive service. The improved approach has significantly reduced the number of patients being admitted. Or can I have that one back, please? So, for instance, in December, we had 22 cases, and 21 of which remained in the community. Now, previously, we would have seen probably a third of those people or more admitted into hospital. So we can start to see that there are some tangible positive results across the board. Thank you.
Brilliant. Thank you all so much for giving an excellent overview of all of the hard work that you put in. And it really is hard work, isn't it? You know, like a lot of time and effort and work goes into the sort of collating these recommendations, and I think it really comes through. Before we move on to the sort of personal reflections, I wonder if it's worth us just picking up Steve's question in the chat. So Steve has asked whether in Cornwall the PCNs were well established already. So I'm going to hand over to Christiana to answer that one.
Yeah, so the PCNs were well established. Oh, thank you, Claire. The PCNs were well established. The problem was that some of the GP practice within one PCN were adding more caseload to the CMHTs. So what we've suggested was to the HCP practices we suggested to move between CMHTs. They would remain in the same PCN, leading to one PCN be dealing with two CMHTs, depending on what GP practice they were using, if that makes sense. The PCNs itself wasn't a problem. The problem was some of the PCNs would give more workload to the CMHT they were working with. So moving these GP practices around would even the workload, if that makes sense.
Thank you, Christiana. So I'm hoping that answers your question, Steve. So it was really just looking at the referral process. So yeah, we didn't restructure the PCN themselves. All of the practices stayed within their existing PCNs. But what happened was that within the PCN, you could have potentially different referral pathways, depending on, again, geographically which CMHT the practice itself was linked to. So hopefully that answers your question. If there are no other questions, oh, sorry, Steve.
No, just saying thank you very much.
Oh, no problem. Okay, if there's nothing else specifically related to the presentation, oh, James Kelly.
Thanks very much. This might not be specifically related to the content. I just wondered, to all participants, how you juggled your competing priorities of clinical work with doing transformation work, if you would be able to say a little bit about that potentially.
Thanks very much for your question, James. I wonder if we could just hold fire just a little longer, because we might get some responses in our personal reflections segment here. But absolutely brilliant question. Thanks for asking it. Shall we head to personal reflections, Claire?
Yeah, no problem. And thanks, James, for the question. So yeah, as I've already said, thank you all very, very much for taking the time out of your very busy clinical days to come and share your experiences with us. And yeah, it's been really nice actually to recap on the work that was done and hear some updates. So we're going to go through now just some questions and just some kind of personal reflections, really. So obviously, it's very different doing clear program, and taking that time out, having that space to do this kind of work can be quite a bit a journey. And so it'd be really great to hear your reflections on kind of what taking part in that was like. So I'm going to start off with asking what you would say your key positive takeaways have been from participating in the programme. And I think perhaps I'll come to Mike first. We'll go in order, but I'll switch it up each time. So you're just on mute, Mike.
Sorry about that. How long we got for this, the key takeaways bit, so I don't go on?
As long as you need, Mike.
Oh, okay. Right. So, I mean, in no particular order, but my key takeaways on a personal level, I've been doing the job I'd been doing for quite a while. I knew there was better ways of doing it. I knew that I was in a pond and there was a bigger sea out there, and you know it wasn't working great there. So for me, it was really mentally refreshing to go on the secondment. Gave me space to think, be creative. Put me in a position to explore things that were facing the trust. You know, make me a bit more of an agent of change, as it were. So that was empowering for sure. So then to become a part of that side of the system improvement and the transformation, again, it was really just mentally stimulating. Also to meet so many people, because we were trust wide. We were literally meeting people, CAMs, from frontline, from all across the geography, from all localities, adults and children's, different care groups. Just meeting so many people from frontline to head of clinical services to associate directors and strategic clinical, you name it. We met loads of people right at every level of the organisation, which was really good. And it was really positive. You know, there was like I said, there was the will to bring about change if we can. So for me, getting that exposure was also great, and also meeting the other Clear associates and the Clear faculty was brilliant. Getting their fresh perspective, the training that they offered was really good, really informative, really well structured, and a good mix, if you will, of online, in person. It was nice to go down to London and just see, you know, down to see the big smoke, as it were, and just yeah, some of that kind of like group dynamics were great, to develop the common purpose. The methodology was good too. I loved the mix of the really in-depth qualitative and quantitative, and I'll talk about that in a minute, about the challenges. Yeah, and I suppose one really key takeaway for me at a very personal level was that I started off this secondment as a transition frontline worker in an LD service, and through the process I found out about a new team that was being set up kind of in parallel with this agenda that I'm presenting about today, how to improve transitions. So I found out, and I don't think I would have found out about this new team, of which I'm now the team manager. So I think that wouldn't have happened without being on the programme. So, you know, that's a tangible outcome for me.
Lovely, thanks, Mike. We love to hear a tangible outcome and impact. But yeah, no, I agree completely. It was lovely. I was thought when we did get the opportunity to all get together and again have that shared learning between the sites and hopefully that sense of kind of being on a journey together. I'm going to come across to Gail and Magda now and see if you've got any thoughts on kind of what your key positive takeaways have been from taking part.
It was a very positive project, and the positive outcomes went far beyond just developing new service. It was just also developing a set of skills personally that Gail are using. So for me, it was really significant development from operational way of thinking to a strategic way of thinking. And when we approached this project, I was looking at this internally. So what's going on within the team, what the team is doing well and well, whether they follow the processes. When we started the project, it was just eye-opener to look at it from different perspectives. So how are we being seen by commissioners? Are we helpful to GPs? Are we helpful to hospitals? How we work together across systems? So my way of thinking changed, and that was actually quite helpful with my job as well, because I got a promotion as an outcome of the project as well. Well, it's not only the project, but that was significant key learning. So from operational manager, I became a deputy service lead, and for Gail it was actually 2 promotions to become eventually service lead as well. So the skills that we learned are not only helpful with redesigning this, but they are helpful with improving other services that are under us. Gail has 9 services under her. I have 7 services, and I'm using the skills that I learned at Clear project. I'm applying them, working with other services. Also, what was a big learning as well, that although we developed design for a big design for this, that is hospital at home, and is still not fully in place because it cost significant money. It's a long process. Applying quick wins and also adding to quick wins some other changes. So for us, it was developing the step up care between our own services, the team managers developing collaborative way of working with General Hospital. Just make such a significant difference to this service, how it is perceived, how it is helpful, what it does to patients. So without even having this 1.8 million pounds for complete redesign, the impact on patients, their carers, prevention of admissions is huge, just with these quick wins and a couple of other changes.
Brilliant. Thank you, Matt, and congratulations. Sorry, I didn't say congratulations, Mike, as well. And Gail, congratulations all round. Well, that's an apologies, Tracy. I didn't mean to miss you off there at all. And thank you so much for putting your reflections into the chat. Gail, do you have anything to add to what Magda said on this one?
Just a couple of points I'll sort of add on for my own personal sort of reflection. One of the big things I got from it is working with data. So we all work with data all the time anyway, but this made me stop and think and focus on not just this is the number, but what is it actually telling me? What's behind this? This data says X has happened or X number of things have happened, but why has that actually happened? So it's that not just accepting a number and moving on, but thinking about the narrative that sits behind the figures that we get so often as managers. And I will say it was a delight to work with the Clear team, and it also was. We had a team of associates, of which Magda and Tracy are both here today, and it was fabulous to work with your own colleagues in a different way, in a different space, and to think differently. And that's been really helpful moving forward, to think differently about other people that you work with, to not just think, oh, they know this, that's all they know, but to be more open-minded to what other people know and what other people bring to projects. And I think that's been really helpful too.
That's really nice to hear. And I think, again, building almost on what Mike was saying as well about the opportunity to speak to people that you otherwise would never speak to, you know, but again, not just that, but working more closely with colleagues that maybe you do actually interact with, but you don't, like you say, know the depth of their skills or knowledge or insights or impact. So that's really nice to hear. And Christiana.
Yeah, because I come from a little bit of a different role, my key takeaways were mainly to be able to work in a totally different speciality and have that wide open um, um, perspective of what the mental health services are and how great they actually are. But also to have the opportunity to develop data analysis skills, such as Gail just mentioned, and the opportunity to be involved in building solutions to improve care and to work collaboratively with the workforce to promote change. I think that's my key takeaways.
Amazing, thank you. Right, so we've talked positives, but as with all things, things are rarely completely smooth sailing. So if we move along now to think about any challenges that you faced along the way, obviously, again, if you overcame, reflect on that too. But yeah, and perhaps shall I come to Tracy, because it's not fair to keep making you type.
That's okay. Hello, everyone. I think, well, Gail and Magda will definitely attest, and obviously everyone will, but it was my team. I worked in the team that was actually being looked at. And a lot of the challenges were when you'd go out and you'd have the conversations with other people, and what was being said, I knew wasn't true from my perspective. And that's what Gail and Magda were very much, but this is what you do. This is the bigger picture you need to pick up on. So I think actually having both of them there to and obviously the Clear team as well to sort of guide each through definitely made me stronger. My reflection skills have definitely improved on, you know, you can only do what you can do, and actually what people perceive you haven't got any impact on anyway. But I think that was one of the hardest things, was actually hearing those little bits and not being able to have any answer, or just having to live with it. And also, like Gail said in the presentation, some of the data didn't quite match up. Some of our data was old and it hadn't been able to be collected for what we needed it. And we did an awful lot of work around that wasn't picked up because it was the signposting and that kind of stuff, so which wasn't then logged as information taking forward. But yeah, it was definitely made me a stronger person from having gone through that as well. So
and again, the learning point around that data not being captured is also a really useful learning point for future to take forward, isn't it? Because again, it's often that missed activity that it's not coded anywhere, and it actually contributes to significant workload. So again, thinking sort of moving forward how that can be captured so it's visible to people is so important. And again, yeah, Tracy, I remember from the beginning and just saying we just have to sit, we've got to take our own bias aside, we just have to sit and accept that this is someone's opinion. We may agree or disagree, but we have to just, and it's really hard. And so, you know, really, really well done for managing to keep that throughout the programme. I'm conscious of the time, so what I might do is, if it's all right with Gail and Magda, because we've had a reflection from Tracy from NSFT, is I'll come to Christiana next, and then we can hopefully get inputs from everybody for our final reflection.
Yeah, so the challenges that I found essentially was to work with data, because it's a very big, it can be a very big task with lots to learn about when you start doing it. But I found that the Clear program is very, very supporting and is very well structured to help us develop those skills. So I think that one was the biggest challenge for me.
I think that's come through from quite a few of the reflections, actually, because again, as you say, we collect a lot of data as clinicians, we record things, but actually having the opportunity to step back and have the time to look and analyse it in detail is not always something that we get the time for. So that's great to hear. Mike, I'll come to you next.
About challenges. I mean, it depends how you paint a challenge, because, you know, genuinely the challenges were the learning opportunities. But I know, but what I think was it Steve before said, this was a challenge, splitting 2.5 days doing Claire, which was you got immersed in the data sets. You know, we looked at a 10-year data set, and trawling through what's called Portal was no mean feat, and trying to get up and running with that takes time, and brilliant, but at the same time mentally quite tiring. so doing your day job as well was quite difficult. But you know, I come from a really supportive team, and the trust is really supportive. So overall, that was I could deal with that, but it wasn't easy, but I could deal with it, and it was a great opportunity. Yeah, like I said, getting to grips with the data portal wasn't easy. I loved the talking to people, and that comes very naturally. The crunching the data sets and getting your head around the terminology of the mental health services data set and all that sort of stuff, not easy but brilliant at the same time. And I now find myself saying, well, what's the time from referral to first contact and so on, which is all about what you get from the data set. And that's one of the challenge was a learning curve, so a positive also. Yeah, and I think major challenge for us was the fact that it's just such a huge breadth of a project. To be fair, you know, some people are looking at teams in here, which I used to envy them because it was quite boundaried, whereas we were talking to just so many different stakeholders across so many different teams, adults and children. So that again had its pros and cons, but you know, it wasn't easy. And I will say that it's by no means a quick fix. So it's a challenge that our recommendations haven't been fully implemented, but at the same time I'm an absolute realist, and I know that we're well and truly on the right direction of travel now as a trust, and we're conscious of the issues and we're tackling them.
Thanks, Mike. And yeah, it's difficult, isn't it? It's kind of worms with engagement and data and all of it, and especially, you know, with mental health, it's a service that intersects with lots of other different services, isn't it? So again, once you start pulling on that thread and you realise, oh, actually, but I've spoken to them, but now I need to speak to them, and I should probably also speak to that team and that team and that team, and you know, it snowballs, which is a great opportunity, but absolutely can at times feel overwhelming. And thank you, Gail. I can see you've popped in the chat about the sort of importance of sort of trying to make boundaries again, for the time to do it. So again, having those clear pathways about who to contact so that you're not getting constantly contacted when you're in your kind of protected clear time, and certainly trying to, I think, work across two roles is really difficult. Absolutely. Okay, so our final my final question to you all is, do you now feel confident that you can take what you've learned from this programme forward into future projects that you'll be involved in, or have you done that already in the intervening year? And perhaps I'll come to Gail first this time.
I think I'm using the things I've learned in everyday practice now. So particularly that thing around what I was talking about, it sounds very dull, but talking about the data. In my current post, I see a lot of reports for a lot of teams, and now I'm not just thinking, okay, well, they're not doing very well. It's were they doing very well last month? Will they do very well next month? What can we do to change it? What does this actually mean? What impact does this have on the services? How do we communicate where our difficulties are? How do we rectify what we need to rectify? Lots of other things too, Claire, but that I think I could go on all day.
Oh, thank you. Brilliant. Magda, I'll come to you next.
Yes, so apart from what Gay said, also with smaller changes between different teams, like quality improvement projects, when you don't necessarily design whole service, but when we can use the skills that we developed to support the managers to make some changes between the teams, and making changes on a smaller scale, but changes that make a significant impact on service users.
Absolutely. I think that's the thing. It doesn't always have to be the mega big change, does it? Like sometimes the small changes, and like you said earlier, the quick wins can have equally as big an impact. So it's great to hear that you're using those skills for those sort of smaller projects and the quicker wins as well. Mike, I'll come to you.
Yeah, absolutely. You know, I think in a nutshell, Claire's all about there's an issue, there's a problem. How do we understand that problem, and how can we improve, or you know, find ways to address and resolve, improve outcomes, etc., and efficiencies, and you name it, patient care, quality, financial benefits. That's the way I approach my day-to-day workload, and without a shadow of doubt, the Claire methodology, the project, the opportunity, the whole thing has just really enhanced my skills in a number of ways. Some which are hard to even fully quantify, but I know for a fact that it's every day I'm utilizing the skills that I've learned for sure.
Thanks, Mike. And lastly, I'll come to you briefly, Christiana, as well.
Yeah, so I feel absolutely more confident because being part of the CLEAR program gave me the opportunity to develop skills in data, for example, that I did not have, and that was, I think, for me, that was like a big.
Oh, I think we've lost Christiana to the internet. Okay, whilst we're seeing if she pops back, I can see that also Tracy and Gail have also popped some comments in the chat. So thank you both for writing out. Sorry, Christiana, we lost you, but I think you're back. Or not.
Can you hear me now?
Yes, we can.
Yes, I was saying I feel a lot more confident now because being part of the program gave me the opportunity to develop skills, not only in data analysis, but also developing and managing a quality improvement project, which it's transferable skills for any future.
Perfect. Thank you all very, very much. All right, we've got 4 minutes. I can see no other questions in the chat, although Paul has made a comment about stopping talking about takeaways, and you're right, I'm feeling really hungry as well. And now thinking about takeaways, I'm trying to be good. But John, should I hand back over to you?
Yes, please, Claire. Thank you. And thank you to all of our speakers today. That was a really, really engaging session. I think we could have carried on and on for a long, long time. And James, I think we answered your question around finding the time to actually engage in transformation with all these other competing demands. So thanks for your question. Very conscious now that unless we've got any other questions, I'll open the floor still for a minute or so. If we don't answer all questions now, then you've got our contact details at the very end that I'll share with you. Do we have any final questions from anybody on the call? No? Okay. If anything occurs to you, because there's a lot. Oh, here we go, Lisa. Hello. Ask away.
Hi, yes. Firstly, just well done, everybody, for such a great session. So thank you very much for that. I just wanted to know whether you sort of had something that made a service or model of care sustainable in the long term, and how you go about sort of ensuring that when you're thinking about making your new models of care.
Does anybody have any particular thoughts on creating sustainable models of care? Anyone want to take that one? Anything that you feel needs to be in place to make things potentially able to keep going? I think, Mike, have you just unmuted? I'm hoping that means
yeah, I mean, I have, because I can't answer it specifically because our model of care isn't fully up and running, but what we have got is the means of addressing what the cost of to certain services are, and how the benefits that you can have from better proactive intervention at an earlier stage. So there are ways of saying, if we can achieve this, the data quite rightly tells us that this is going to be sustainable because we're currently spending X and we know that these improvements will bring out Y. So that kind of sustainability model is inbuilt into the CLEAR methodology.
Perfect. Thank you very much. All right. I won't elaborate any further. I'll hand back to John, just because, again, conscious we're rapidly approaching one.
Yeah, thank you, Claire, and thank you again to everybody involved and everybody who's joined us today. I think Paul has quite rightly, and ourselves have mentioned takeaways far too many times that we'll just think about lunch now. I know my tummy's rumbling. What I will say is that I'm going to share a link to all of these mental health program case studies in the chat in a moment, so you can read in a lot more detail not only those case studies but case studies from other programs over the past couple of years, so you can read at your leisure. Alex, if we can just bring up a slide quickly on our next webinar. Okay, so the next Impact Series webinar will be Friday the 22nd of March from 12 till 1, and that will focus on the CLEAR UEC Frimley 2023 programme, and it's entitled Improving UEC Services for Older People Living with Frailty. So we'll be live from 12, and we really hope to see you there. And finally, for me, the contact details, if you want to get hold of us. Do we have a final slide, or should I know this by now? Thanks, Alex. Okay, here we go. Oh, that's awful, isn't it? I should know this off by heart. In fact, I do. It's the www.clearprogram.org.uk. You can find out all about the National Clear Programme there. If you want to email us any other questions that you might have wanted to ask today, but we ran out of time, or you think about when you watch the recording or look through the slides early next week, check email info@clearprogram.org.uk. And we're also on Twitter, also known as X, @Clear4Care. That's it for now. Thank you again, everybody. It's been a pleasure. I'll be sharing the webinar recording and the webinar slides on our website early next week, so keep an eye out for that. Thanks so much for your time. Enjoy your lunch, and I'll see you soon. Bye for now.